Hi everyone, this is Neel Raithatha, consultant, audiologist and director of earwax. Thank you for joining me in my latest video using the wax scope. And here we have a patient who has to attend, believe it or not, every 4 to 5 months, and they're only 14. And they'll be coming to the clinic this regularly since, and I'm just checking my notes, since 2021. And we've referred to ENT on a couple of occasions, but unfortunately there's not much that can be done. This patient has been given antibiotic eardrops in the past, so they suffer from otitis externa, and as a result they accumulate a lot of dead skin in their ear, and I'm just not sure what the root cause is. They have got another ENT appointment coming up, a follow-up, but at present the only real treatment is to have their ears cleaned on a regular basis. Now, they've got a very narrow entrance to the ear canal, but even with really, really narrow ears now, I'm tending to use our medium-sized speculum more and more. And I'm just using the left-hand side of the specular. And the specular is the black ring that you can see on the outside of the image. And it's essentially a funnel. So the tip is narrower than the proximal end, so the end that attaches to the wax scope. And specula are used with otoscopes. So if you go visit your doctor or your nurse and you have your ears examined, they have an ear torch with a specular attachment. And the function of the specular is to stretch and straighten the ear canal. And they come in different sizes. And previously I would use the smaller size specular in this ear. But I'm just more and more comfortable now using the medium-sized specular, even for really narrow ears. It's not to say that I still don't use the smaller size specular, I do, but I'm less reliant upon it now. They've got very strange consistencies. So the dead skin and the wax I removed from the entrance was really soft and mushy. But as we get deeper, the wax on the skin gets really dry and crumbly and hardened. Now, I've removed the lateral bit, and you can see that plug really deep in there, that's quite dark. So I'm just, again, using the left-hand side of the spec to stretch open the first bend. And I'm just focusing at the moment on the deeper wax. So when you've got deeper hardened wax with some softer wax in front of it, if you remove the harder wax, occasionally it brings out the softer wax at the same time. But you can see even that harder wax, the end of the suction tip is just embedding into it. Now what I'm doing, I'm just mopping up this is the patient's second bend. I'm just clearing that a little bit just so I can get a slightly better view, because there's some wax hanging out there, protruding the view. And I think I'm just going to focus now back on the posterior canal wall and trying to peel it from here. The slight issue we've got, we just don't know how thick this layer is. So when I'm approaching it, I've got to be quite gentle. If I push too hard with the suction probe, we're going to hit the canal wall. But it just wasn't really coming away as I would hope. And I've put some drops in already. I think I've just put a bit more drops there. And once more, I'm just straightening and stretching the ear canal. And I think I'm going to go to the top part here, the roof of the ear canal, and peel downwards. And just to see what happens. Sometimes when you're removing wax, it's like a game of Jenga. You remove one block and everything just falls. And it's the same with earwax. Sometimes you just remove a bit of wax from a certain area and everything else becomes a lot easier. So I think I'm going to focus again on the deeper wax, because I just feel that is going to come away. So this is probably about half a centimetre away from the eardrum, so it is quite deep. But with the introduction of some olive oil spray, I've just got a slightly better suction grip here. But it is stuck in the inferior recess, so there's a little trench just in front of the eardrum at the floor. And you'll see some residual, really dry, crumbly wax and skin in there, which we will also remove. So I'm just mopping up a bit of the entrance. Again, that's the second bend to the right. And I'm just going to focus again on this wax on the peripheral posterior canal wall. And with the introduction of the drops, it's just coming away a bit easier now. So going to just separate that plug. I'm going to just give it a little wriggle, trying to tease it out of the ear. As I did, it just broke away. So patients who have otitis externa and a lot of skin accumulation, they tend to have this very mushy consistency of dead skin, particularly more laterally near the entrance, and it can dry up a bit deeper. So see the colour difference as well. This is a lot darker, this is the deeper wax, and just trying to separate it from the roof of the ear canal. And I've just got a section here. We've got to just, again, try to wriggle this out of the ear. So I'm just rocking it up and down and coming away at the same time. So the eardrum is in the distance now, but we're just going to mop up so we get a full view. Because we're working close to the canal walls, we're just going to be careful that we don't make direct contact and cause trauma. So I think I'm just going to get the wax. I'll get that in a minute. You'll see some wax in the trench just in front of the eardrum, so that'll be coming up in a moment. You can just see the consistency. It's really sticky and mushy. And there is a bit of a crusted layer of skin at the floor of the ear canal near the entrance, so we're going to remove that as well for the patient. For now, I'm going to go to the eardrum. So you've got this wax there. So that's settled on the eardrum in the inferior recess. So I've got a really good view. I'm using a 17 gauge suction tip. So it's a smaller suction tip here. Fortunately, it's coming away in pellets. It's not embedded against the eardrum. It's quite loose wax, so it's coming away nicely. And with the wax scope, removing deep wax like that, it can be much easier compared to head-borne microscopes. So there's a bit at the top, so I'm going to zoom into this. So quite often, I think I should use the zoom function a bit more, but because you tend to manage, you kind of quite honestly forget about it, but on that occasion I decided to use it. So now we're just going to mop up just past the second bend here to the right. So there's some crusted skin here. So it's quite glossy. I'm just going to glide across the surface of the canal wall, and then I'm going to stretch the ear again and look to the back part. So there's always a blind spot just behind the first bend, because in the case of the right ear, you enter the ear. When you enter the ear, you're almost going up 1 o'clock, and then about half a centimetre in at the beginning of the first bend, you kind of then have to reorientate and go probably about 11 o'clock in direction, maybe even 10 o'clock, and then you reach the hidden crevice behind the first bend, and then you reorientate again back to about 1 o'clock towards the eardrum. So here we're angling the specular around 10, half 10. We're using the side of the specular, as mentioned, to stretch open so we can visualize this. Now again, I've just got to kiss the surface. You can see the difference between the bone and the cartilage region. So the more paler skin, that's the cartilage, and the redder skin where I'm going now, this is the bony part of the ear canal. I'm just hovering across, and as I am peeling it away. And the skin just tears away. There's a bit of it flakes away at the end, but I just leave that little tail end because we don't want it to clarinet. I think it was slightly clarineting there. So I'm just going all the way around the edge. And then this is at the juncture between the cartilage and the bone. So the cartilage forms the outer third of the ear, whereas the bone forms the inner 2/3. And then this is all in the cartilage region here. So this is just entering the first bend. Probably see this with the naked eye. So I'm just sliding across, mopping up, and we're going to re-enter the ear, going to have a look at the eardrum. And, well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.